Welcome to our video on abdominal aortic aneurysm. Let's begin. Before we start, we'd like to note that there are unruptured and ruptured abdominal aortic aneurysms. It's best to think of these as a continuum, where rupture is a progression of the disease, which can then be stable or unstable based on the patient's blood pressure and mental status. We'll be discussing the definition, pathophysiology, risk factors, clinical features, and then the diagnosis and management of abdominal aortic aneurysms. Aortic aneurysm is defined as full-thickness dilatation of blood vessel that is greater than 50% increase past baseline. A key point here is that it's a full-thickness dilatation to be considered a true aneurysm. Fake aneurysms can occur in the abdomen, but they are less common and have a different pathophysiology. For adults, the average diameter of abdominal aorta is 2 centimeters, so anything greater than 3 centimeters is considered aneurysmal. The exact pathophysiology of abdominal aortic aneurysms, or AAAs, requires further research, though it is due to a failure of the structural proteins of the aorta, such as elastin. This results in weakening of the aortic wall. Contributing factors appear to be genetic associations, marked inflammation, and proteolytic degradation of the connective tissue. The eventual complication of AAAs is when the tissue has lost enough support and it ruptures. Here is a gross anatomy photo of an infrarenal aneurysm. The regions of the aorta distal to the renal arteries have less collagen laminar unit. We know that collagen is what provides structural support, so aneurysms here are more common compared to the thoracic aorta. Before I go any further, I'd like to mention that these images were contributed by Amboss. So thanks to our partnership with Amboss, I can highlight several important features of aortic aneurysm. How are true and false aneurysms differentiated? A true aneurysm is a full-thickness dilatation of the vessel wall. This means it involves the adventitia, media, and intima. However, in this image we can also see a dissecting aneurysm and a false aneurysm. The false aneurysm forms when there is a perforation of the vessel wall and accumulation of extravascular hematoma, while dissecting aneurysm is found when there is an intimal tear in the vessel wall and formation of a second lumen, also called false lumen. The main risk factor of AAAs, which is also modifiable, is tobacco use. Incidence is also higher in males over the age of 60 who are Caucasian. For family history, it is considered positive if a first-degree relative has had an abdominal aortic aneurysm. Abdominal aortic aneurysms are generally asymptomatic and therefore discovered on routine screening or as an incidental finding from imaging obtained for another purpose. However, features of a ruptured AAA is a pulsatile abdominal mass in a patient with sudden and severe abdominal pain and hypotension. Let's try a question. A 30-year-old Caucasian male presents to his primary care physician with concerns of his potential for developing an abdominal aortic dissection, which his father was recently diagnosed with. What are the key elements of the discussion to have with this patient? This patient's concerns can be distilled down to a discussion of risk factors for abdominal aortic aneurysms. One point of conversation would be his increased risk because he is male and has a positive family history. Being Caucasian is also a risk factor. A key point for the physician is to obtain a smoking history because it is a modifiable risk factor for the development of abdominal aortic aneurysms later in life. The diagnosis of asymptomatic aneurysms are based on the maximal diameter of the abdominal aorta. The diagnosis is achieved by a CT scan or ultrasound. A diameter greater than 3 centimeters is considered aneurysmal, between 4 and 5.5 being medium, greater than 5.5 is a large, and greater than 6 being very large. However, the diagnosis of a ruptured AAA is mainly clinical, with the triad of hypotension, pulsatile abdominal mass, and severe and sudden abdominal pain. If there is no evidence of a pulsatile abdominal mass, then the diagnosis can be made with just hypotension and sudden and severe abdominal pain and imaging showing an aneurysm. Let's continue with this algorithm to elaborate on workup and management of AAAs. Evaluation for patients suspected to have a AAA will be divided into symptomatic or asymptomatic. For asymptomatic patients, specifically males aged 65 to 75 years who have ever smoked, screening with abdominal ultrasound is recommended. It is considered positive for AAA if the diameter of abdominal aorta is greater than 3 centimeters with or without thrombus. Next, for symptomatic patients with the triad of hypotension, sudden and severe abdominal pain, and a pulsatile mass, medical stabilization is required. If stabilization is successful, then abdominal CT is recommended. For unsuccessful resuscitations, if there is known history of AAA, then it is considered ruptured until proven otherwise in the operating room. If there is no history of AAA in the unstable patient, then bedside ultrasound should be performed. and is considered positive for AAA with the diameter being greater than 3 centimeters with or without thrombus. On the other hand, for symptomatic patients with less specific symptoms like flank pain, abdominal CT is performed and is considered positive for AAA with the diameter being greater than 3 centimeters with or without thrombus. This is an abdominal ultrasound of the aorta. We can see the true lumen here. The section here is the mural thrombus. And finally, this entire structure is the aortic aneurysm. Here is a CT scan to help visualize what would be seen for a ruptured AAA. To orient the CT, a vertebral body is here, bowel here, and the aorta here. Next to the aorta, we can see blood outside the aorta next to a disruption in the aorta wall. This is evidence of rupture. Management of asymptomatic patients with confirmed AAA include regular screening ultrasounds. However, if the diameter of abdominal aorta is greater than 5.5, expanding 1 centimeter in a year or 0.5 in 6 months, surgical repair is indicated. For symptomatic patients, surgical repair is definitive treatment, though medical management may be attempted as a bridge. Let's discuss those surgical techniques for management of a ruptured AAA. EVAR, or open. Endovascular aneurysm repair, or EVAR, is for stable patients due to the need for CT scan to determine eligibility. The CT is required because it lets us know if there is enough space between the takeoff of the renal arteries and the start of the aneurysm to deploy the stent. If there is not, then EVAR is not possible and an open repair is required. So open repair is indicated for hemodynamically unstable patients or for stable patients with aneurysms that are too adjacent to the renal arteries. For endovascular stent replacement, the catheter is inserted into the femoral artery. The stent and catheter are advanced past the aneurysm. Afterwards, the stent is released from the catheter and the catheter is pulled back from the incision site. The stent graft allows blood flow through the aorta without further pressure being applied to the weakened vessel wall. Let's end this lecture with a review question. A 57-year-old female presents to the emergency department with a chief complaint of severe abdominal pain. She reports the pain started 20 minutes ago while driving to work and is the worst abdominal pain of her life. Her vital signs include blood pressure of 98/45, pulse of 120, respiratory rate of 18, oxygen saturations of 94%, and temperature of 37 degrees Celsius. An abdominal ultrasound shows 5.1 centimeter abdominal aortic aneurysm just below the renal arteries and a negative FAST exam. Patient is sent for a CT scan to help in the diagnosis. In what ways was the care of this patient mismanaged? A FAST exam should not have been performed. B, a point-of-care glucose should have been obtained first. C, patient required urgent surgical consultation. Or D, blood cultures should have been obtained prior to CT. The resident was likely comforted by the lack of free fluid in the peritoneum, which is what the FAST exam was looking for. But remember, the absence of free fluid does not rule out rupture. The aorta is retroperitoneal, so a ruptured AAA wouldn't reveal fluid in the peritoneal cavity. Only normotensive patients should go to the CT scanner. So where was this patient mismanaged? The point the resident sent the patient for CT imaging. Instead, the surgeon should have been contacted immediately for presumed ruptured AAA. And this makes C the correct answer. A is wrong because in a hypotensive patient with abdominal pain, a FAST exam is clinically indicated. While a point-of-care glucose is useful in the resuscitations, this patient presentation is not consistent with hypoglycemia or a hyperglycemia state, which is why B is wrong. Blood cultures are not required prior to CT scans, but are indicated prior to antibiotics in critically ill patients. So D is wrong, and that concludes the section.